A 65-year-old male presents with symptoms of bone pain, particularly in the lumbar region, and fatigue over several months. He also reports polydipsia and polyuria. His past medical history is significant for hypertension, managed with lisinopril, and no known drug allergies. Physical examination reveals normal vital signs. Laboratory investigations indicate hypercalcemia, anemia, and renal insufficiency. Serum protein electrophoresis demonstrates a monoclonal protein spike, and urinalysis shows low-grade proteinuria with normal albumin levels, suggesting the presence of non-albumin proteins. These findings are consistent with a diagnosis of multiple myeloma. Now the question is, what's the next best step in management? Stick around till the end, and we'll divulge the cunning tricks and critical insights about this vignette, secrets that are beyond the grasp of your average med student. Our goal at Avg Med Student is to make the highest quality and most up-to-date content on USMLE while bringing it to you at no cost at all. If you could please subscribe, leave some thoughtful feedback, and share the content if it helped you in any way. We'd really appreciate it. The patient's chief complaints include persistent bone pain, localized to the lumbar area, marked fatigue that has been worsening over several months, alongside symptoms of polydipsia and polyuria. His medical history is notable for hypertension, which has been managed with the angiotensin-converting enzyme inhibitor, lisinopril, without any reported allergies. Upon evaluation, the patient's vital signs are found to be within normal parameters. However, the laboratory investigations reveal a triad of concerning findings: hypercalcemia, anemia, and renal insufficiency. A critical piece of diagnostic evidence comes from serum protein electrophoresis, which shows a monoclonal protein spike. This finding is a hallmark of multiple myeloma and suggests the overproduction of monoclonal immunoglobulins by malignant plasma cells. Additionally, urinalysis results indicate low-grade proteinuria with normal albumin levels, which is characteristic of the presence of monoclonal light chains rather than the albumin typically detected in common renal pathologies. These monoclonal light chains, or Bence-Jones proteins, are indicative of multiple myeloma, but are not adequately detected by standard urine protein tests due to their non-albumin nature. Given the diagnosis of multiple myeloma and its associated renal complication, myeloma cast nephropathy, the decision-making process regarding the next best step in management involves several options. A. Initiating chemotherapy with bortezomib and dexamethasone. This combination is a cornerstone in the treatment of multiple myeloma, targeting the malignant plasma cells directly to reduce the production of monoclonal proteins that contribute to disease pathology. It's crucial to assess the patient's renal function before starting treatment, as certain chemotherapy agents may require dose adjustments or may be contraindicated in the context of renal insufficiency. Trick to watch out for. Bortezomib, although renal safe, can cause peripheral neuropathy. Ensure the patient is monitored for symptoms of neuropathy, such as numbness or tingling in the hands and feet, which could significantly affect quality of life. B. Starting broad-spectrum antibiotics and ordering a renal ultrasound. This approach might be considered if there was suspicion of an infectious process or a need for structural evaluation of the kidneys, but it does not directly address the underlying myeloma or its immediate complications. Trick to watch out for. Avoid the potential overuse of antibiotics without clear evidence of infection, as this can lead to antibiotic resistance and may complicate future treatments if an actual infection arises. C. Beginning treatment with high-dose intravenous immunoglobulins. While useful in certain conditions involving the immune system, this option does not target the root cause of multiple myeloma or directly address its renal complications. Trick to watch out for. IVIG is expensive and can have side effects such as headache, allergic reactions, and rarely thrombotic events. Misusing IVIG in a scenario where it's not indicated can lead to unnecessary risks and healthcare costs. D. Performing a kidney biopsy to confirm the diagnosis of myeloma cast nephropathy. Although this could provide definitive pathological evidence of myeloma cast nephropathy, it may not be immediately necessary for the management of the patient's current complications. Trick to watch out for. Consider the patient's clinical stability and coagulation status before proceeding with a biopsy. In patients with severe thrombocytopenia or coagulopathy, the risk of bleeding may outweigh the diagnostic benefit. E. Administering intravenous fluids and considering starting bisphosphonates for hypercalcemia. Trick to watch out for. While hydrating the patient, Monitor for signs of fluid overload, especially in those with compromised cardiac function. When starting bisphosphonates, be vigilant about the risk of hypocalcemia and osteonecrosis of the jaw, advising the patient on proper dental hygiene and the need for dental evaluation before treatment. This management strategy addresses the acute issues of renal insufficiency and hypercalcemia. Adequate hydration is crucial for flushing out the light chains that contribute to renal damage, while bisphosphonates are effective in managing hypercalcemia by inhibiting osteoclast-mediated bone resorption, a common problem in multiple myeloma due to the increased osteoclastic activity driven by malignant plasma cells. The optimal choice, based on the patient's immediate clinical needs and the pathophysiology of multiple myeloma, is option E. This approach not only targets the urgent complications of hypercalcemia and potential renal failure, but also sets a foundation for the stabilization of the patient's condition, allowing for the safer initiation of chemotherapy to address the underlying malignancy. It is imperative to manage these acute complications promptly to improve the patient's overall prognosis and quality of life before proceeding with the broader treatment strategy for multiple myeloma. If you feel above average today as a med student, go ahead, give yourself a cookie and a pat on the back. You deserve it, fam. Until next time, peace.